Hello, everyone. I want to just thank everyone for coming this evening to our Walden Phi Nu Inspiring Scholarship and Social Change Symposium series for September 2020. And so in order for us to begin this great event, I want to just say thank you so much for joining us this evening. During the presentations, we will have all the microphones placed on mute so that our speakers can have an opportunity to present their presentation and not be distracted with background noises. During the presentation, each participant and presenter will have 25 minutes to give their presentation, and we will allot 5 minutes after the conclusion of their presentations for any questions and answers that we can provide for you. One thing that we do ask for you is to please post into the chat box any questions that you will have, and we will address them after the presenter finishes his and her presentation. Please note that this session will be recorded and a link will be sent to you after the entire webinar is completed. We have two speakers today. One of them is a tag team. And before I introduce them, let's get a few preliminaries out of the way. Those nice, great disclosures. So this session is jointly provided by Walden University and Sigma Phi Nu chapter. The planners and presenters of this nursing continuing professional development activity disclose that there are no relevant financial relationships, those held by the planner or significant other, currently or within the last 12 months, with commercial interests. No relationship exists for the nurse planner or presenters, which could influence the planning or implementation of this activity. The planners and presenters have disclosed no financial interest or receive any in-kind materials that could influence the presentation of this material. Also, lastly, please note that this activity will not have any live captionist. Our goal is to have the recorded event captioned for later viewing. With this presentation, in order to obtain contact hours for this presentation, at the conclusion of the webinar, a new window will appear for you to complete the evaluation and download or print your certificate. Or if you are watching an archived version, you will return to the Walden University Continuing Education System, click that you have completed the material, then you will be able to complete the evaluation and download or print your certificate at that moment. So let's get into who we're having tonight. The Walden Sigma Theta Tau International Chapter Phi Nu, along with Walden University School of Nursing, jointly want to offer a quarterly webinar symposium. With this, you get one free CE. And our presenters today are Kim Stevens, with a DNP MSN RN, and accompanying her on this joint presentation is Corey Stevens with an MSN BSN. And their title of their presentation is Promoting Healthy Workplaces Through User-Centered EHR E-Learning. Our second presenter is Holly Gautier-Wetzel. She has a PhD, MSN, BSN, and is an RN board certified. And her topic for today's presentation is going to be related to the barcode medication administration in the emergency department to mitigate medication errors. So let's begin, and I will introduce our first two co-presenters. A little history about Kim Stevens. Dr. Kim Stevens is a registered nurse with 26 years of practice and a DNP graduate of Walden University. Kim currently practices as a supervisor nurse consultant, informatics, as well as a visiting professor for Purdue University Northwest RN, BSN, and graduate nurse curriculum. Improving users' experience with the usability of information systems and clinical applications is Kim's focus. Along with Kim this evening, her second presenter is Corey Stevens. And Corey is a NCC board certified informatics nurse specialist, and a senior HIMSS member who holds a BSN from Indiana University, an MSN in Nursing Informatics from Walden University, and the CPH IMS certification. Corey is an informatics nurse consultant in the Department of Clinical Research Informatics at the National Institute of Health Clinical Center and a virtual academic coach in the nursing department of Youngstown State University. Corey is a member of Sigma Theta Tau Walden University Phi Nu chapter. He is very active in the Health Information Management and Systems Society, having volunteered and presented at the HIMSS Global Health IT conferences as well. In addition, Corey is a member of the Tiger International Task Force Leadership Team, where he voluntarily serves as the domestic co-chair liaison. Notably, he was awarded the HIMSS Early Career Service Award for 2020 and is a contributing author of the 5th edition of Nursing Informatics, Where Caring and Technology Meet. So Dr. Stevens and Corey Stevens, I now turn over the presentation to you, and we look forward to hearing about promoting healthy workspaces through user-centered EHR e-learning.
Thank you, Lisa. Good evening, everyone. Trying to share my screen here. There we go. We're so excited to present to you today healthy workspaces through user-centered EHR e-learning. So let me begin by reintroducing your speakers today. I'd like to introduce myself. I'm Dr. Kim Stevens, and the co-presenter tonight is Corey Stevens. We're both informaticists that worked at the National Institute of Health, and we're Walden alumni. But before we get started, we wanted to let everyone know that there's no conflict of interest for either one of us, and our views are our own. So let's get started with the agenda for tonight's presentation. We would like to invite you all to come on a journey with us. We want you to discover how a small EHR training team updated its EHR training program for the non-prescriber users, which increased satisfaction with training, improved effectiveness of training, and ultimately increased the organizational efficiency rapidly. The new training format also allowed learners to complete their training at their own pace in the comfort of their homes using private devices, promoting healthy workspaces. We even saved paper and made the training process much greener. The agenda for I'm sorry, can you hear me?
Oh, sorry, I just wanted to make sure you know you're not in presenter mode, so we can't see the full screen.
Oh, okay. Hold on one second. Let me try again, Sarah. Thank you, friends.
IT issues never happen, right, Kim?
Right, never. So let's try this again. Hold on, guys. I'm sorry for that. How?
Perfect. Thank you, Kim.
Okay. Okay. How about there? Can you see, or are you looking at my notes now?
This is perfect.
Okay, perfect. And let me get to the agenda. So the agenda for tonight is we will start with the learning objectives. We will talk about nursing informatics, barriers with the project, rapid training optimization model, the methods that we were using, our results, and our recommendation. The learning objectives for today would be to apply the rapid training optimization model for user-centered EHR training to address organizational needs and creating healthy workspaces. We're going to describe the importance of evidence-based, user-centered EHR training for non-prescribers. identify, to redesign an EHR training program for non-describers, assess how an EHR training program meets organizational requirements, and evaluate the impact of user-centered EHR training on organizational efficiency. So I would like to give you a little bit of background on the project's facility. The project was implemented in a large research center that conducted IT services for over 2,000 staff members and over 5,000 technical devices. The current electronic health record system, and we will go by the name of Chris for that one, was implemented in 2004 and is made available to all users by several different devices, such as WOWs, thin clients, virtual desktops, as well as a mobile application. And it supports over 65 different role types.
That's right. And with this rich history and evolution of electronic health records at the project site, it can be easily argued that EHR training could and should be just as evolved. This project actually began as my nursing informatics graduate student project in my practicum experience under Dr. Stevens. Our premise was that if you entered the healthcare workforce within the last decade, you probably have never charted on paper. This is important because modern EHR training should reflect the needs of today's healthcare workforce. If your EHR training hasn't changed much from when you first implemented the EHR years ago, then it's time to evaluate how the training program meets the needs of your organization today. And that's exactly what we've done. So take a moment to think about this question. How many years of experience do you have using EHRs? Less than 1 year, 1 to 3 years, 3 to 5 years, greater than 5 years? Awesome. And I see someone said greater than 5 years. Another one said greater than 5 years. Awesome. Yep. Keep sending that in the chat, guys. So we asked the same question to our organization, to clinicians coming through our existing EHR training, and this is how they responded. There is a sizable number of people with more than 5 years of experience and with less than 1 year. What this tells us is that many of our learners come to our training already comfortable using EHRs as seasoned clinicians, or at least comfortable using computers and other information systems, as many early careerists possess these skills. So data helped us build a foundation for our project, and we wanted to strengthen it with evidence-based practice. Our literature search revealed that EHRs have been around since the 1960s, and they are in high use during the last decade as a result of the HITECH Act and other national programs. Again, this tells us that EHR training should be just as evolved as EHRs themselves and should meet the needs of today's healthcare workforce. We wanted to consider generational differences since millennials make up a large and ever-increasing proportion of healthcare workers. Millennials expect training on demand, such as through e-learning. In addition, e-learning has been found to be as effective as traditional in-person learning, is more efficient, and provides the flexibility for shift workers, who are an important target group in EHR training because they often report feeling neglected if they work the night shift. Furthermore, we wanted to make sure our training met the needs of as many learners as possible. And we discovered that blended training, which is a mix of in-person and online training, is most learner-centric. And definitely the use of the learning management system is a big factor in a successful training program.
Absolutely, Corey. So a little bit about the previous training format before we implemented this project. The users had to come in, and possibly if you were a nurse or one of the other roles that worked a lot in the EHR, you could have up to 4 very long CBTs that was launched from computer devices that was stored in a classroom type setting, requiring learners to attend training in person and stay until the completion of the course or the end of a 3-hour offering. The training also included several paper processes, such as rosters, the post-training assessment, the job aids were paper, and not to forget the certificate of completion. That probably resided in a folder for the day someone asks you if you completed training after you've already had access, right? Everybody keeps their completion of their certificate of completion. So we have a second poll we'd like for you to think about. And what format is your EHR training at your organization? Is it online for self-paced learning? Is it instructor-led? Is it blended, a little bit of online, a little bit, in person, or is it unit-based? So I see some results coming in the chat, and keep those going. We'll go back and we'll discuss those, or you guys can look at those answers yourself as we move forward. The analysis of the training format identified quite a few gaps. Learners were forced to take training on scenarios that wasn't specific to their role. For example, lab techs were forced to complete nursing scenarios with training on documentation or order entry. And of course, what a nurse would do in the EHR will be different than what a lab technician will do in the EHR. We had issues with users registering for an offer. It was quite complicated and many times requiring extra support for completion. There were only 12 workstations available, so only 12 people can train at one time. And during the summer months, if you work in a teaching hospital, you definitely understand what I'm saying here. The request for training increased, and we did not have the bandwidth to predict how much resources we would need to meet the training demands. Now, to conduct training in the previous format was very expensive. Think of the costs for the extra effort in assisting learners with registering for a course because they were not able to do that independently. So that interrupted your work task that you had to complete for that day. Not using automatic processes to mark learners successful after completion of the course. The facilitators would have to manually go in and complete that process. Since the training did not reflect individual learning roles, it was sometimes difficult to complete. If you can imagine being a lab technician and then having to listen about how to document I's and O's, and some of the nursing language, it's just very difficult to complete if that's not what you do every day. And then to think about all of the different paper processes that were in place. One of the things that I really remember was a colorful folder that we got at the end of training. And in that folder, we had just loads and loads of paper there available in case you needed it to do your job, or if you forgot how to do a task in the EHR once you started to work at the bedside. But to just sum all of that up, the training program was quite expensive.
It became clear to us that this was not evidence-based, user-centered EHR training anymore, so we needed a solution. We didn't have a budget, but we did have existing resources and some creativity. Spoiler alert, we accomplished all of this without having to purchase new systems nor hire out, saving our organization tens of thousands of dollars. Our proposal consisted of engineering role-based training for the 65 different roles at the clinical center, leveraging the learning management system to administer and track the training, and making the training available anywhere, anytime. Kim, can you go back one slide?
I think it's only going forward, Corey. Let's see. Here we go.
Yep, that one. Great. So we wanted to reduce our risks and chance for scope creep. So we prepared ourselves for some anticipated barriers and challenges. Importantly, the RTO model helped us face these challenges and the challenges that we didn't see coming. So what is the RTO model? RTO stands for Rapid Training Optimization Model. It is a change management model that enables training teams to accomplish big projects by breaking them into phases. As you can see, within each phase, there is a life cycle, and between each phase, there is a time buffer for stabilization. Stabilization is very important to reinforce the change that occurred in the previous phase and give people time to adjust. Stabilization also helps the project team to assess new barriers and pivot if indicated. Furthermore, using the RTO model, you can break these projects into as many phases as needed. So in the next few slides, you'll see how the RTO model helped us to tackle each of these methods and achieve success in our training optimization project.
So at the beginning, and doing an analysis and starting planning, the training team that were healthcare professionals, we had nurses, we had a pharmacist on our team, but what they weren't were trained instructional designers. So they had to quickly identify, or we had to quickly identify, the need to increase knowledge on instructional design methodologies. We attended e-learning conferences. We tried some web-based learning courses. We engaged with online resources such as YouTube and Twitter. We would even hashtag the authoring tool that we would use just to get inside of a community to help us if we needed help or just to get some type of support with our configuring or building the e-learning content. We interviewed and met with trainers from other facilities, as well as researching scholarly journals, which was conducted to implement evidence-based changes to the new training format. We took baby steps with the implementation by starting off testing one course in the classroom with a facilitator there for elbow support. The first course tested with the introductory course for view only and offered in the LMS. So remember, the original course was not in the LMS. It was housed on the computer in the classroom. So now we wanted to leverage the project by placing the learning in the LMS in hopes that the course will be offered remotely later. So the LMS would support that. But the first phase, learners had to come to the training room and take the training so that the team can make modifications in real time from the feedback of the learners. For an example, a user may verbalize, "I wish you could go at your own speed with the slides and reading, since once I finish the scenarios, I will have to wait for the slide to continue reading the information to me." At that time, we were able to go in, modify the training, load it back in the LMS, and just make those slow changes to implement the content to meet the learner's need. So testing was going well, and then we ran into a new barrier. The enterprise browsers were not compatible with the LMS system, and a side project to mitigate that issue was conducted. So again, project scope creep.
That's right. And because of the RTO model, we were able to pivot right then and take care of that new barrier that popped up.
Absolutely.
So in our organization, the learning management system had never been used for this kind of training. So it took some preparation to get it ready for us. We requested our own domain where only our training would live and where we could customize notifications to learners and completion requirements. While this phase was underway, we were working on a parallel phase, building the first course. When the first course was ready, we put it into our domain in the LMS and continued through several more phases of the RTO model until we were ready to put all courses and curricula into the LMS. As we mentioned, we already had computer-based tutorials, or CBTs, but they were long, not role-based, and learners could only complete them by coming into the training lab. We took these long CBTs and divided them into building blocks that could be assigned to various curricula targeting the learner's role. For example, instead of having to sit through 90 minutes of the original order entry CBT, learners who only use one function of order entry could finish this part of their training in 30 minutes or less, thanks to the targeted training that we created. Ultimately, the 4 long CBTs were broken down into 8 shorter building blocks. These training building blocks were arranged into role-based curricula that we call training tracks. It wasn't easy determining which roles needed what part of each training, but we accomplished this through analyzing documentation the training team kept and interviewing clinical managers who knew exactly what their staff did in the EHR. We found that visual representation of the training tracks helped others to understand how the training tracks worked. For example, you can see the nursing track on screen with each of its 8 building block courses below it. The nursing track got all of the courses, but the other tracks get fewer according to how their role utilizes the EHR. On the far right, you can see all 10 tracks represented by the circles. We use color-coded names for tracks that are shared among various roles for ease of communication. For instance, the green track, our most fundamental track, contained only the introduction course. Many roles only require the introduction course, so they complete the green track. As you can see, there are 5 roles that got their own tracks because their training was unique. Grouping courses into these training tracks made it simple for learners to know what they needed to take, as well as for verifying training completion before giving access to the EHR. Learners really latched on to the color-coded training tracks and often reported things like, "I'm done with the blue track."
Yes. And then after that, we replaced the paper PTA with a simulated PTA. The simulated PTA mirrored the real environment of the EHR. The simulation was configured to force learners to select the correct answers to all the questions, as well as providing data on completion status for the training team. All learners completed the PTA successfully with this format, ensuring the training team that desired knowledge level was obtained. And the next phase was to redesign the website. Self-registration for training was encouraged for all users, regardless of the training delivery that was chosen, remote or in the classroom. The website redesign was intended to make the website landing page easy to read and to follow for successful registration. Access to the website was made public so that learners could register and complete training on any device, anytime, anywhere, effortlessly. We also developed walkthrough tutorials and placed them on the website to help the users to be very helpful guiding learners in the registration process to reduce the need for extra support in order to complete that task. We then increased this implementation by mirroring the initial phase of how the learners were registering into the introductory course and getting them registered into the introductory curriculum, the green track, as Corey mentioned earlier. So again, we were testing. Testing was going well. And then the team was able to troubleshoot in real time and to prevent the project scope creep. But after the troubleshooting, we ran into another barrier. We had an issue with the enterprise browsers not meeting the needs of the LMS. But once again, thanks to the RTO model, we were able to manage that project scope creep efficiently and effectively. So moving along with the project, we were getting closer to implementation. So we needed a support system to make sure that we had all the documents to support the learners as well as the training team. So we developed a support plan to ensure there was a smooth transition from the old training format to the new one. And of course, when you're dealing with technology, you're going to have a downtime process for cases where the LMS was not available, but you still had to conduct training. We educated our help desk, who are our tier 1 support team, on how the process have changed and how they can assist us with triaging calls effectively. We created a troubleshooting guide. So the troubleshooting guide was easy, accessible for the understanding on how to move users forward if there were issues that presented itself. We had a trainer session to get all of the training team prepared and ready for the go live, as well as the course evaluations. Because with the course evaluations, we were able to take that information and make modification that was needed. Now, after preparing for the go live, we had to do marketing. Communication was needed to the stakeholders of the training for the training. I don't know. I'm sorry, guys. I'm being distracted. But however, our goal was to build the brand. We had to build a brand for the new training team. We needed adoption so that the users would use this new training format and made sure that our stakeholders would be happy and we would have a successful implementation.
So on screen, you can see our images from our marketing campaign to help build brand awareness for our new program called Chris eLearning. We shared these images through emails, newsletters, posters, and flyers to drive engagement and get people excited about how easy it is to complete their EHR training now. As you can see, we promoted learning anytime, anywhere, on demand, which aligns with the remote training option that learners now had. We even created a commercial video that you can view by clicking on the link at the bottom of the slide.
Hi, this is your 5-minute warning.
Thanks, Lisa. We just have a few more slides left. So really quick, let's look at the results of our project. So we collected evaluations from after every training. And so what you're going to see are some results from those. Look at how the data changed from 2018, which was before our project, to 2019, when we began to offer remote training through our project. Look at how many learners chose to complete their training remotely. So we were able to double our learners because of remote training, and most of them chose remote training. And we didn't lose any satisfaction scores either. In fact, they raised a little bit. Since we implemented blended training, our post-training satisfaction scores have remained high, and learners feel confident in their ability to use the system. And you can see some of the comments that we received. And this slide shows that many people completed remote training, and the ones who didn't actually wished they would have. So you see some of the people who did it in the lab actually changed their mind and said, oh, I wish I would have done this remotely. And finally, we can't forget the help desk. They're very important. So we actually were able to prove that through our blended training program, we were able to reduce support calls by 25%. And that's pretty significant.
Absolutely. At the time of identifying the need for this project, we were not aware of the current COVID-19 pandemic. However, the pandemic hit, and we were prepared to update and maximize the training program to be available 100% remote within a week, eliminating the need for in-classroom training. Clinicians could complete EHR training, again, from the comfort of their home on their private devices. Risk of exposure of the virus was minimized for staff and patients. Stress was reduced for learners and facilitators. Staff was able to complete the onboarding process and have access to the EHR system, overall promoting a healthy workplace. So real quick, just some recommendations if you guys are considering changing your EHR training format. A diverse skill set from graduate students and experienced professionals across generations can help a training program as we saw in ours. The pandemic has taught us a lot, especially that we can't predict the future. A blended training program enables organizations to respond to these type of situations and not lose efficiency in onboarding new staff. When optimizing a training program, the RTO model is helpful to quickly implement a functional blended or remote training program. So that is the end of our presentation. And if you have any questions, here is our contact. You can contact or connect with us on any of these social media channels, and we'll ask any questions that you have if we're not able to address them tonight during the presentation. Thank you guys for listening. Any questions now?
Kim, I have a question. This is Sarah. If you had users training remotely, how was support handled for them? Were they able to call your help desk if they couldn't get something to work? I'm just wondering what kind of support you could offer to them for some of our friends.
So Sarah, for me, you were going in and out. Corey, were you able to hear the entire question?
It sounded a little bit like the Matrix. So no, I couldn't hear everything. Sorry.
Let me try again. For the folks that were training at home, what kind of support did you offer them?
Oh, absolutely. If they ran into trouble with the training while doing it in the LMS?
Yes, ma'am.
Okay, great. So in doing the website, we upfront let them know what avenues they have for support, that they could email our team or they can call the help desk. But I think the most innovative support system that we had is that we had a link inside of the training where they were able to communicate it with us in real time. So when they clicked the link, there was a form that popped up that they would fill out with their contact information. And we on Microsoft Teams, I'm not trying to promote a vendor, but on Teams, we were able to get those alert and notifications in real time and respond to the users as they were doing the training. So we had those notifications on our phone, on our mobile devices, as well as our laptops or desktop devices in order to be supportive in real time for our users.
Awesome, thank you.
You're welcome.
All righty, I don't see any other questions. Great presentation, Kim and Corey. I will now take control again. I love that title. I'll take control. Keep it interesting. Our next speaker for the evening is Holly Gauthier-Wetzel. And she's going to be presenting on the barcode medication administration in the emergency department to mitigate medication errors. So Dr. Holly Gauthier-Wetzel earned her PhD in nursing education from Walden University. She is a certified online instructor, holds a Lean Six Sigma Green Belt, and is an ANCC board certified nurse informatician. Dr. Wetzel is an employee of the Center of Innovation, COIN, in Health Services Research at the Health Equity and Rural Outreach Innovation Center with the Ralph H. Johnson Charleston, Virginia Medical Center. So Dr. Wetzel, I will now turn the screen over to you for your presentation.
Okay, can you see my screen?
Yes, ma'am, we're ready to go.
All right.
Thank
So
you,
sorry
Holly.
for that delay, everyone. Okay, well, again, thank you for the introduction, and I apologize for the technical difficulties. We always have some, right? As we learned from that previous presentation, a lot of barriers. So today I'd like to discuss a patient safety issue that's plagued our profession for many years, medication errors. The topic of my presentation is barcode medication administration, or I'll refer to as BCMA, in the emergency department to mitigate medication errors. This phase in the medication process, the administration phase, is considered the most critical because no bedside nurse, not only do bedside nurses have to catch their own potential mistakes, but also mistakes made by prescribers, pharmacists, medication process. First, I'd like to provide a brief summary of my study, the research question, hypothesis, and participant selection. Then I'll provide the results of my study and how or if the results relate to the current literature. I will end my presentation by explaining the theoretical framework and offer the limitations of my study as well as the recommendations for future research and possible implications for social change. To share a little background, electronic health record systems have been adopted in healthcare facilities in hopes to help integrate workflow processes of the healthcare profession. Studies have demonstrated that the addition of BCMA technology has decreased medication errors within hospitals and long-term care facilities. However, even after adoption of the EHR systems, hospitals have been known to have different documentation practices for medication administration in the emergency department compared to inpatient units. Limited research has been conducted to establish whether using barcode technology to document medication administration in outpatient units has decreased medication error rates. For my study, I wanted to investigate medication error rates before and after this technology was used to document medications given in the emergency department. A comparative descriptive research design was used for my quantitative non-experimental research study. Transitional care model and continuity of care provided the theoretical and conceptual framework. Secondary data was analyzed for this case study. So the research question for this study was, what is the comparison in medication error rates between documenting medications given by using an electronic nursing note compared to using BCMA technology, only for patients ordered to have medications administered in the emergency department prior to transferring to an inpatient unit. So ultimately, what I wanted to see was if there was a difference in medication error rates after BCMA was implemented in the emergency department, as compared to simply documenting the medication as given within an electronic nursing note. This study will determine whether the null hypothesis is accepted or rejected. Is there a relationship between medication error rates when we compare these documentation practices? Is there a relationship between the dependent variable, medication error rate, and the independent variables, medication documentation within electronic nursing note and medication documentation within BCMA technology? Using secondary data, the participant selections were veterans that served within our military forces including Army, Navy, Air Force, Marines, and Coast Guards, as well as their dependents if the veteran was 100% service-connected or retired from the military. The location of this study was a VA medical center in southeastern region of the United States. You can guess where that was. Patient charts reviewed were those veterans or eligible dependents that were treated in the emergency department at this location, ordered to receive medication in the emergency department, then transferred to an inpatient unit at this VA medical center. So they had to have been seen in the emergency department, had medications ordered, and received those medications prior to transferring to another unit within the same VA. So literature revealed that 33% of reported medication errors are associated with medication administration phase prior to using BCMA software to scan medications as given within the electronic health record. And literature also suggested that on average, the use of BCMA to document medication administration reduced medication errors by 50%. So I entered this information into the binomial distribution calculator, as seen on this slide, to determine the number of patient charts I needed to review for medication errors. The required sample size for my study for 2 arms to achieve 80% power were determined by the number of subjects in my study, which equaled 236. To assure an adequate amount of data was collected, I reviewed an additional 11 charts per time frame. This resulted in a total of 258 charts reviewed for this study. 129 charts were reviewed for possible medication errors, both pre and post BCMA. I began reviewing records beginning on the day before BCMA software was implemented in the ED and went backwards until I collected 129 records of patients that met all participant criteria. Then for post-BCMA record collecting, I allowed a 6-week stabilization period after BCMA was implemented in the ED, then started reviewing charts until I collected 129 records of patients that met all participant criteria for post-BCMA. So out of the 129 patient records reviewed pre-BCMA, 36 medication errors were present. This accounted for 27.9% of patient records, which you see right here. Post-BCMA data revealed the medication errors were present in 22 of the 129 records reviewed, accounting for 17.1% of patient records. This resulted in an observed 10.8% difference in medication errors between using the electronic nursing note and using BCMA to document medication given in the emergency department. Descriptive statistics were computed for each study variable. Using an electronic nursing note, the average number of medications given in error per chart was 0.47. The average number of medication without error per chart was 246, or 247, I'm sorry. Using BCMA, the average number of medications given by error per chart was 0.26, and the average number of medications given without error per chart was 2.68. Therefore, using BCMA in the emergency department decreased the average number of medications given in error per chart by 21%. The combination of these results concluded that the null hypothesis is rejected. There is a relationship in medication error rates between documenting medications given by using an electronic nursing note compared to using BCMA technology for patients ordered to have medications administered in the ED prior to transferring to an inpatient unit. Well, that's not really surprising, right? I knew I would, well, I shouldn't say I knew I'd find those results, but I was pretty much there. As a matter of fact, I remember the coordinator for my program saying BCMA is well known to decrease medication errors, Holly. Let's do something else. But remember in my first slide saying there really isn't any literature stating that medication errors are reduced in outpatient areas. If you look at records for inpatients, you can see medication administration throughout the stay. But once you start going into GI or dialysis or places like that, some hospitals still don't use the same electronic health record in those outpatient areas. So not really surprising. These findings are similar to recent literature regarding BCMA use in medication error reduction. However, as you will see on the next slide, an additional 2 findings emerged from this study. First, 3 different documentation methods were used to document medication that was given in the emergency department. And the second finding was that nurses were documenting the administration of medication in the emergency department with no corresponding medication order. Kind of scary, right? Recognized during post-BCMA data collection period when BCMA was to be the only source for documenting medication administration except during a critical or emergent situation, I discovered that medications were documented as given in an electronic nursing note, BCMA, or the combination of both. An electronic nursing note was used to document medication 12.4% of patient records. None of these medications identified were considered critical or emergent. BCMA technology was used to document 84.5% of patient records, and both were used to document at 3.1% of patient records. These statistics identified 15.5% of patient records that had their medication documented within various areas of the EHR, creating an inconsistent documentation practice which could result in adverse event. I would like to note that because the medications were given, accounted for, and documented, these occurrences were not counted as medication errors within this study, as opposed to this slide. Another finding within the study included medication documented as given within a nursing note with no associated written order to administer the medication. 6 events were identified before BCMA was implemented, and 2 events were identified after BCMA. Because no order was written to give medications, these events were recognized as medication errors within this study. These statistics identify 6.3% of patient records have medication documented as given without an accompanying order. Did somebody say liability insurance? Just as the literature has demonstrated a decrease in medication errors after BCMA was implemented within an inpatient area of hospital and long-term care facility, the use of BCMA and ED also mitigated medication errors for this outpatient area. However, the data revealed that there are challenges after BCMA software implementation. Many studies have revealed that workarounds may be used to expedite the process involved in electronic documentation. Studies have also identified cases when providers missed documenting patient care because the electronic documentation process was so cumbersome. The findings within this study, inconsistency in documentation practices and medication documented as given with no associated order, suggest further exploration is needed to identify the perception of BCMA software technology and the workflow as viewed by all emergency department providers involved in the medication process. The transitional care theory and continuity of care concepts were used as the framework for the study. Transitional care theory is used to increase outcomes for patients who transfer from one care setting to another. There are 3 components of continuity of care: informational, relational, and management, all of which are needed to assure safe medication process. Informational continuity is the communication component when transferring patient information. Relational continuity is the relationship between one provider to the next. Now, technology is considered relational because electronic devices communicate from one device to another. Management continuity is the consistency of care. For this study, management continuity means the consistent medication documentation practices within the electronic health record, so each provider knows where to find previously documented medication. Many studies have demonstrated that transfer documentation is the most important part of patient transfer process. Inconsistency in documentation practices may lead to medication errors. This study was conducted at the VA Medical Center, located in southeastern United States. Although BCMA technology is nationally fielded throughout the VA system, the results of this study may reflect user issues with local providers and technological issues established from local information technology departments, making this a limitation in this study. Next, this government institute uses an electronic health record specific to the VA medical centers throughout the nation. This
Holly, you
electronic
have
health
5
record-
minutes.
Okay,
Sorry.
got 2 more slides, I think.
Okay.
Thank you. This electronic health record is not compatible with the community record system. Next, the stabilization period for implementing new technology may fluctuate from one hospital setting to the next, depending on user experience and comfort level. Finally, the emergency department is not always chaotic, but when it is, it can be emotionally, physically, and mentally draining. The data collected could represent a time of chaos or calm, depending on when it was collected. Recommendations for future research. This study analyzed 10.8% decrease in medication errors after BCMA was implemented. My study results support other previous literature. However, medication errors are still occurring. Further research is needed regarding implementation of the EHR system and the impact it has on provider workflow. Previous studies have stated the emergency room nurses perform unsafe workarounds so they can process patients through quickly. Various studies, including mine, indicate medication errors occur. However, many do not address whether the patient experienced harm as a result of the medication error. Based on the results of this study, further research is needed to examine the reason medication errors continue to occur, as well as the long-term impact of the medication errors. Through this study, we have found that the use of BCMA technology in the emergency department has decreased medication errors. Therefore, implications for positive social change include our patients not experiencing medication errors, which could cause significant morbidity or death. Lessening medication errors could decrease the burden on family, friends caring for the patient, and decrease litigation costs for the organization. Just as soldiers follow direction in war to protect our country, nurses that care for our veterans need to follow direction at work to protect our veterans. Inconsistent forms of documenting medication administration within the electronic health record may lead to medication errors. The study findings suggest further research is needed to identify the perception of BCMA technology and documentation workflow as viewed by the emergency department providers. Nurses are the center of healthcare. They organize care and coordinate with all disciplines to provide safe patient transfers throughout the day. Nurses try their best to maximize timeliness, value, and efficiency and minimize injury, error, and inconvenience within the healthcare system. It is critically important that nurses understand the impact of electronic charting and continuity of patient care. Thank you all for helping to improve patient experiences and promote safety within our healthcare environments. I admire you for everything you do. Thank you. And there's my references.
I have a question for you, Holly. What
Certainly.
would you recommend be the next step in maybe And how would you collect that information if a patient was harmed during a medical administration error? You know, a lot of
What-
those are documented.
Right. What we'd have to do, and I've talked to the research department about this since I've been there. I just got just got this job in March, so we would have to follow the patients. Like the 22 that I got post BCMA, I would just follow those patients and see if those medication errors, say it was hypertensive medication, follow their vital signs, or if it was medication for, I don't know, whatever medication their diagnosis was for, just to follow them. Maybe they received the wrong medication, but it would be very involved because you'd have to follow the patient. So it couldn't, I don't think that it could be a large population, so it wouldn't be as generalizable, but it would be doable.
Thank you. And we have a question
Good
from
question.
the audience. Did you notice any workarounds with med administration in your research?
I wasn't able to, everything that I did was secondary data. So I've got 3 research projects spun off of this one study. And one of the research projects is a qualitative, and I'm not a qualitative person, but I'm going to do it. I'll be interviewing and surveying nursing staff in the emergency department. Another huge, because I presented this at our facility as well, and managers and nurse educators aren't aware of the workarounds that are being used, and that's another limitation of the study.
Wow, that is interesting that they find workarounds. Well, Dr. Wentz, I thank you so much for your presentation, as well as Dr. Stevens and Corey. And to all the participants for tonight, I know we ran a little over, but thank you for bearing with us for technical difficulties. So I am Dr. Elizabeth Rodriguez. I am your host for this evening's presentation. I want to again thank you for joining Walden University and Sigma Phi Nu chapter. Unfortunately, at the end of the conclusion of this webinar, you won't receive the pop-up window for your certificate, but Phi Nu will be emailing tomorrow the link for you to be able to retrieve your CE credit. And that also will apply if you're watching an archived version. At that point, you will be able to return to the Walden University education system, click on that completed the material, and you will be able to complete the evaluation and download and print your certificate. So on behalf of Walden University and Phi Nu, we want to wish everyone a great evening, enjoy the rest of the week, and thank you again for participating in this awesome webinar.